left ventricular dysfunction in critically ill patients admitted in intensive medical care unit. This study was done in South India in a tertiary care medical center.
Dr. Dursamy, do you want us to share your slides in the full screen mode?
Can you can you share, please?
Of course.
Thank you. Thank you. Can you go to the next slide, please? So this study is mainly based on left ventricular dysfunction in critically ill patients. Acute left ventricular dysfunction is common in the critical care setting and more frequently affects the elderly and patients with comorbidities. Myocardial ischemia often causes acute left ventricular dysfunction, which affects 8 to 30% of critically ill patients. So this left ventricular dysfunction most commonly we use to assess using echocardiogram. So echocardiography is ideally suited to quantify LV dysfunction and determine its most likely cause. Although LV dysfunction suggests a worse prognosis, appropriate therapy can optimize the outcomes in critically ill patients. The study was done in South India in a tertiary care center. It was done to study the prevalence of myocardial dysfunction among critically ill patients admitted in the intensive medical care unit. So this is a cross-sectional study done in patients, 615 patients. So how we define critical illness? Critical illness is defined as any life-threatening condition that requires pharmacological and or mechanical support of vital organ functions, without which death would be imminent. So based on this definition, the study was conducted and the patients are segregated as critical illness patients and without critical illness. And in those patients, myocardial dysfunction was estimated by using echocardiography. So all critically ill patients admitted to the intensive medical care unit studied during the period of 6 months. And the patients with the known structural heart disease and the patients with the coronary heart disease with myocardial dysfunction are excluded from this study. Among 615 patients studied in were included in our study. Among those, 342 were male patients and 273 were female patients, which constitutes about 44.4% in male and 55.5% in female patients. So comorbidities like systemic hypertension had 206 patients and 340 had diabetes mellitus. So among 615 patients in critically ill patients, 126 had myocardial dysfunction. This 126 patients constitute about 20% of all admitted patients in the intensive medical care unit. Among those 20% of patients with myocardial dysfunction, the most common causes listed are chronic kidney disease, sepsis, followed by pneumonia, acute CVA, scar pain sting. So the CKD constitutes about 21.4% and sepsis about 19%. And pneumonia, especially atypical pneumonia, constitutes about 9.5%, followed by acute CVA, scar pain sting, snake bite, hanging, then multiple tablet poisoning, then followed by rat killer poisoning, anemia, and interstitial lung disease. So most common cause of myocardial dysfunction listed in my study is CKD, sepsis, pneumonia, and CVA. Among those, CKD constitutes the higher percentage. Among 1 or 2 patients with the CKD admitted in intensive medical care unit, 27% of patients had myocardial dysfunction. And in patients with sepsis, 131 had sepsis in critically intensive medical care unit, which constitutes about 24% of myocardial dysfunction. Especially urosepsis constitutes the highest percentage in this study. And patients with pneumonia, 68 patients studied. Among those, 12 patients, 12% have myocardial dysfunction. And patients with acute CVA, 163 patients were reported. Among those, 10% had myocardial dysfunction. So patients with the CKD, pneumonia, especially atypical pneumonia, and patients with the sepsis, urosepsis, and acute CVA brainstem hemorrhage admitted to the intensive medical care unit need routine cardiac evaluation. So finally, to conclude, therefore, it is essential to conduct echocardiographic screening on all critically ill patients to identify myocardial dysfunction earlier and to prevent complications by providing optimized medical treatment in those patients. Yeah, thank you. Thank you for this opportunity.
Theory, and I work in Italy. I'm a cardiologist in Italy. What I'm going to talk about is heart failure and some new strategies to treat heart failure with reduced ejection fraction. We know that heart failure is a major concern all over the world. It has a high prevalence and also a high incidence in developed countries. And we know that it is related to an increased rate of hospitalizations, relating to an increase in costs, and of course, an increase in morbidity and mortality. Both European and American guidelines share a common approach of introducing 4 pillars in treatment, which are ARNI, beta blockers, MRAs, and SGLT2 inhibitors. We know that if we can manage to introduce these 4 pillars, all 4 pillars, the outcome of patients with reduced ejection fraction improves significantly. Of course, it is not always possible. We know, in fact, that these drugs have some side effects, some contraindications. We know that there are many strategies in order to introduce all of them at the same time. For example, we know that the classical strategy used an old-fashioned strategy was by introducing them one by one. We know that introducing every drug one at a time and up titrating every drug until the maximum tolerated dose hasn't proven to be very effective for some reasons, mainly because we know that if we approach every patient with this strategy, we know that the improvement in ejection fraction is lower, and we know that in the first 3 to 6 months, the patient, if with ejection fraction less than 35%, has an increased risk of, for example, sudden cardiac death. So new strategies have been developed. For example, another strategy uses the introduction of beta blockers and SGLT2 inhibitors at the same time, followed by ARNI and MRAs. With this strategy, we have a quicker escalation of every drug with a better outcome. But most importantly, as we know, often in medicine, there is the need of a tailored strategy, and each patient has its own comorbidities, its own clinical problems. So we know that there cannot be a single strategy that can comprehend every patient. For this reason, we know that today what we usually do is to tailor a strategy for every patient we meet. For example, in patients with an elevated heart rate, we know that, for example, beta blockers or rivaroxaban are the first line, as followed by SGLT2 inhibitors and MRAs. We know that SGLT2 inhibitors can be up titrated, it can be introduced in almost every patient, because we know that the side effects are relatively rare, and we know that they can be used even with a reduced kidney failure, at least until 20 milliliters per minute. And we know that this strategy is much more, not only effective, but also tolerated by patients. In fact, that hypotensive patients do not tolerate ARNI, and if they do not tolerate ARNI, often they just give up with all the other drugs. So we cannot see a significant improvement over time. Another drug that has been developed in latest years that has been brought up by the Victoria trial in 2020 is vericiguat. This drug has a different mechanism from all the other drugs used for heart failure. And we know that this drug can be used not only in patients with an optimized medical therapy with a deteriorating heart failure, but we know that this drug, which has been introduced for patients with a recent decompensated heart failure with an NT-proBNP less than 4,000, ideally, has also been proved in real-world cases, in real-world scenarios, to improve the introduction of all the other drugs. So we can use this drug in order to improve all the other four pillars, the introduction of all the other four pillars, with a mechanism that is still not completely understood, but we know that it works. Of course, it has some problems and some contraindications and some drawbacks. The main one is, of course, the presence of hypotension, which is a common side effect of many drugs for heart failure. In this case, we know that Victoria trial protocol gives us some insights in order to tailor the therapy according to the patient pressure profile. So we know that, for example, we cannot uptitrate the treatment in patient with systolic blood pressure less than 90 millimeters of mercury, but we can do it in patients with a systolic blood pressure more than 100 millimeters of mercury. But apart from the pharmacological therapy that we know that has been proven to be effective, and almost every cardiologist uses nowadays, we know that we can do something else. We can do more. What can we do? We know that device therapies in this case are the main, are another cornerstone of heart failure therapy. I won't talk about CRT because it is a commonly used therapy in our everyday clinical practice. So we know that we do not need, I won't talk about it because it is an established and effective therapy. But what I will talk about is some new device therapies. For example, cardiac contractility modulation. This device uses some high voltage impulses given during the QRS within 70 milliseconds from the peak of the R wave. With this therapy, we can improve the phosphorylation of phospholamban, but also, in this case, what we obtain is an improvement in calcium release inside the cell. We know, in fact, that an increased amount of calcium is released by the sarcoplasmic reticulum. So, in this case, we improve the contractility, but there are also some long-term effects. For example, we know that it increases the phosphorylation of troponin and myosin binding potency, and also reduces the expression of maladaptive genes that are overexpressed in patients with heart failure. In this case, we know that this kind of therapy is very useful in patients with a narrow QRS. We know, in fact, that patients with a wide QRS are often treated can be treated with CRTs and other kind of devices. But in the majority of patients where a QRS is narrow, or there is, for example, not a complete bundle branch block, this kind of therapy is very useful. We know that it is used by implanting two catheters in the right ventricle, separated by 2 centimeters one another. One senses the impulse and the other one gives another impulse during the QRS. We know that due to its high energy, it needs every recharge every week, because we know that high voltage impulses are given, and it gives impulses for 1 hour each, 7 hours a day, organized in 1 hour each. And in this case, we know that high voltage needs a recharge of the battery. There is still not a device in this case capable of pacing. Another device very, very useful in this case is LVEDP. which is left bundle branch area pacing. This kind of pacing is similar to CRT. It follows the same principles because it gives a stimulation in the left bundle branch, which in this case improves conduction and improves myocardial contractility due to a synchronization in both ventricles. We know that this kind of device has a widespread diffusion in latest years because it's very, very effective. And we know that not only it narrows the QRS, but it also improves heart contractility and, of course, has proven to reduce both hospitalization and death for heart failure. There have been some paradigms between between CRT and LVEDP. LVEDP is not always desirable, for example, in patients who have a diffuse conduction disease. In some cases, it's not that helpful, but we know that there is a new kind of device, a new kind of stimulation. In this case, which is the LOT CRT, which is the CRT with an LVEDP in the same patient in order to improve myocardial contractility, even in patients with a scarce response, a reduced response to LVEDP. There is also another device that unfortunately, I haven't experienced my clinical life, but which is the VNS, or vagal nerve stimulation. This device directly stimulates the vagus nerve and thereby reduces the sympathetic tone. By reducing the sympathetic tone, it also reduced not only the cardiotoxic effects of catecholamines, but it also induces some anti-inflammatory and anti-apoptotic actions, and it has been proved to improve myocardial contractility in these patients. Unfortunately, it hasn't been proved to reduce hospitalizations in large trials or cardiovascular death, but it has been effective in improving LVF and, most importantly, quality of life and symptoms in these patients. But we know that all these therapies are very, very effective. Every therapy should be targeted for every patient. We know that not every patient can be, for example, not in every patient we can use this kind of devices, this kind of technologies. But we know that in many patients, there is something even more that we can do. We know, in fact, that both pharmacological and device therapy are widespread, are very diffused in common practice, and almost every patient with heart failure with reduced ejection fraction has, nowadays, most importantly, has a correct, we can say, a proper approach. But not every patient. Not in every patient we have a complete approach and a complete therapy and optimized gestion, even if we use both pharmacological and device therapies. There is something else we can do, which is telemedicine or telehealth. We know that this kind of this branch of our common practice is not always integrated in our programs, but it's very, very important, and most importantly, is very effective. We know, in fact, that telemedicine has been proven to be very effective in reducing both cardiovascular death and, most important, and also cardiovascular rehospitalizations. In patients with heart failure and reduced ejection fraction, there are many devices that we can use. From the CardioMEMS, which is a device implanted in pulmonary artery that detects the systolic pulmonary artery pressure and thereby is used in order to prevent cardiovascular events. We also have some integrated systems inside, for example, the CRTs. We know, in fact, that there are many systems that are used, which can be used, which detect the level of activity of every patient, and also, for example, the pulmonary impedance. So they can, for example, detect an heart failure and an increase in intrapulmonary fluids before having a decompensated heart failure. With these technologies, we can increase, for example, by we can increase, for example, the diuretic therapy in order to prevent an acute event and thereby improving prognosis, because we know that in patients with heart failure, every hospitalization and every acute event is related to a worse prognosis and, of course, an increase, not only a decrease of quality of life, but also an increased rate of death. So we can do that. We know that telehealth is very, very effective because it has proven some reports to reduce both mortality, but also to reduce the rate and length of hospitalizations. And in this case, is very, very effective. Its main effect is the reduced hospitalizations and most importantly, cardiovascular hospitalizations, and most importantly, of course, heart failure hospitalizations. And we know that we can integrate telemedicine in our everyday protocols by using the technologies that we already have. We know that, in fact, in CRTs, we have some devices, for example, algorithms that can detect they can predict heart failure decompensations, but we know that even new devices which are developing these days have a very, very are very, very effective in these patients and can be used in our everyday life, because we know that we can treat every acute patient and we know how to treat most acute patients, even if not always. But in these cases, with these technologies, we can prevent an acute event. We can improve, it can significantly improve not only prognosis and healthcare costs. So, in conclusion, in patients with heart failure and reduced ejection fraction, we know that the future might be bright, we hope so, but it's a very high prevalence disease, and we know that it has a very high impact in our everyday clinical life. We know that a multi-pharmacologic approach is necessary in these patients, and we have some very effective drugs in this disease that can be used in this disease in these patients. And we also have new technologies. We have developing technologies which are also very effective in preventing death and in detecting, for example, deterioration in clinical status. And we can use these devices and these technologies in order to prevent heart failure, hospitalization, and cardiovascular-related death in patients with reduced ejection fraction and that need a particular care and a tailored approach. Thank you.
Of echocardiographic transmitral E by E prime compared to left ventricular end diastolic pressure measured by cardiac catheterization and its association with the severity of coronary artery disease among patients with ischemic heart disease. The study is done in South India. The gold standard for LVEDP determination is cardiac catheterization, which is invasive, expensive, and complex, requiring appropriate equipment and trained operators. Non-invasive evaluation of LVEDP is an important objective of echocardiography. We all know that coronary artery disease is one of the significant causes of mortality. So far, there is a paucity of research on the link between LVEDP measured by left ventricular cath and the extent and severity of CAD as assessed by coronary angiographic syntax scores. The aim of the study is to explore the accuracy of evaluating LVEDP by echo, transmitral E by E prime in comparison with cardiac cath, to investigate and also to investigate the relationship between the extent and severity of CAD and LVEDP in patients with ischemic heart disease. This is the prospective observational study done in 300 patients. We included all patients undergoing coronary angiogram and patients with atrial fibrillation, mitral valve surgery, mitral stenosis or severe mitral calcification, hemodynamic instability, and left ventricular ejection fraction less than 40. Patients were all excluded. We assessed the severity of CAD using syntax scores and compared it with LVEDP, which was measured through echocardiography and cardiac catheterization. The E velocity measured in pulsar Doppler and the annular E prime velocity was taken by taking the average of lateral and septal E prime velocities, and the average annular E prime velocity E prime velocity patients had a severe CAD, which accounts for syntax score more than 32. 80 patients had an intermediate risk, that is syntax score 22 to 32, and 142 patients had a low risk, that is syntax less than 22. Among the 300 patients, 112 patients presented with elevated LVEDP more than 15 that was measured during cardiac catheterization, and all patients had LVEF more than 40%. We obtained the average E by E prime values and found a strong correlation with invasive left ventricular and diastolic pressure measured in cardiac cath. And we did a Pearson correlation coefficient between echocardiographic E by E prime and invasive LVEDP, which was found to be 0.85, which was statistically significant. We obtained the receiver operator characteristic curve for average E by E prime values for LVEDP more than 15. And there was a good area under the curve, which was 94%. This is the ROC curve for LVEDP more than 50, and you can see a good area under the curve of 94%. The Yoden cutoff point of 9.4 had 85.7% sensitivity and 88.3% specificity for elevated LVEDP, that is more than 15. The transmitral E by E prime of more than 9.4 and LVEDP of more than 15 measured by cardiac cath are 91% and 93% sensitive, and 78 and 82 specific for severe CAD. That is, transmitral E by E prime value of more than 9.4 was 91% sensitive, and LVEDP more than 15 was 93% sensitive for severe CAD. And for moderate to severe CAD, that is syntax score more than 22, we got a high specific values of 93.6% for transmitral E by E prime and 96.
I also want to thank Fiona, Kelsey, and the Scientex Associates for the invitation to present my research. I'll be discussing the consumption of linoleic acid on lipid risk markers for cardiovascular disease. I'm Eric Froyen, Associate Professor in the Department of Nutrition and Food Science at Cal Poly Pomona. Cal Poly Pomona is located in Southern California in Los Angeles County. Therefore, it's in a large metropolitan area with a lot of traffic. I only live about 17 miles from campus. However, it takes me about an hour and a half to get home. So it's a long, miserable drive. These are pictures of Cal Poly Pomona. The campus was closed for about 2 years during the COVID-19 pandemic. However, we're fully open now. I just recently completed 2 clinical trials on mangoes and grapes, and I look forward to publishing the results from those studies. And during the COVID pandemic, I attended the Nutrition 2020 online conference, in which Dr. Chris Etherton argued that we should reduce saturated fat as much as possible. However, Dr. Krause indicated that it's not necessary to reduce saturated fat as much as possible. This debate illustrated that we need much more research on the effects of fat consumption on cardiovascular disease risk. I performed a search on omega-3 fatty acids and cardiovascular disease risk markers. However, there are many articles published in this area, therefore I changed my topic. I performed a search on omega-6 fatty acids, such as linoleic acid and cardiovascular disease risk markers, but surprisingly, I could not find a review article discussing the effects of linoleic acid on cardiovascular disease risk markers in healthy individuals. Therefore, I found my topic. This is the outline I'll follow during the presentation: introduction, methods, results, discussion, and fat recommendations to reduce the risk of cardiovascular disease. This table shows the top 10 causes of death in the United States, and the #1 cause of death is heart disease, contributing to over 702,000 deaths, and strokes were the fifth leading cause of death, contributing to over 165,000 deaths. And cardiovascular disease includes heart disease and strokes. And this figure illustrates the leading cause of death in 2021 globally. And again, the number one cause of death is heart disease, contributing to over 8 million deaths, and strokes were the third leading cause of death. A suggested dietary strategy to decrease the risk for cardiovascular disease, again, includes heart disease and stroke, is to decrease the consumption of saturated fatty acids and increase the consumption of monounsaturated fatty acids and polyunsaturated fatty acids, or MUFAs and PUFAs. However, this has been questioned by certain publications and authors, which I'll discuss later in the presentation. This table shows major dietary sources of various fatty acids. So the upper portion shows healthful fatty acids, whereas the lower portion shows harmful fatty acids. However, in a recent update to this textbook, the words healthful and harmful have been removed as we're learning more about the health effects of these fatty acids. Good sources of monounsaturated fatty acids, especially oleic acid, which is the common monounsaturated fatty acid in the diet, include avocados, canola, olive oil, nuts and seeds. Good sources of omega-6 polyunsaturated fatty acids, especially linoleic acid, that's the essential omega-6 fatty acid, include corn, cottonseed, safflower, soybean oils, also nuts and seeds. And good sources of omega-3 polyunsaturated fatty acids, especially alpha-linolenic acid, that's the essential omega-3 fatty acid, include fatty fish, flax seeds, walnuts, soybeans, and canola oil. It should be noted that EPA and DHA, other types of omega-3 fatty acids, are found in fish and seafood, and they are not found in flax seeds, walnuts, soybeans, and canola oil. Good sources of saturated fatty acids include bacon, butter, chocolate, full-fat dairy products, meats, coconut palm oils. Good sources of trans fatty acids include hydrogenated shortening, hydrogenated or partially hydrogenated oils, certain commercial baked goods, donuts, cakes, cookies, snack foods, chips, crackers, and so forth. And there's a little note here at the bottom. Keep in mind that foods contain a mixture of fatty acids, so just not one or two. So when we consume these food items, we consume fat or triglycerides. And here's the triglyceride molecule here, glycerol with 3 fatty acids attached. So these fatty acids can be different. They can include a combination of unsaturated and saturated fatty acids. This table shows oil sources of linoleic acid. So good sources include corn oil, cottonseed oil, grapeseed oil, sesame oil, soybean, sunflower, and walnut oils. Good food sources of linoleic acid include almonds, Brazil nuts, pecans, pine nuts, pistachios, pumpkin seeds, sesame seeds, sunflower seeds, and walnuts. And there are 2 essential fatty acids for humans, which means we need to consume these fatty acids in our diet because we're not able to make them in the body. And the first essential fatty acid is alpha-linolenic acid, which is the essential omega-3 fatty acid. And the second essential fatty acid is linoleic acid, which is the essential omega-6 fatty acid. And linolenic acid is called an omega-3 fatty acid as the first double bond starts at the number 3 carbon from the omega carbon or methyl end. And linoleic acid is the essential omega-6 fatty acid. And it's called an omega-6 fatty acid as the first double bond occurs at the number 6 carbon from the omega carbon or methyl end. And again, we need to consume these fatty acids in our diet because we're not able to make them in the body. And this figure illustrates the metabolic pathways for the omega-6 and omega-3 polyunsaturated fatty acids. These pathways occur in various cells in the body. The omega-6 fatty acid pathway, these fatty acids are considered more pro-inflammatory, whereas the omega-3 fatty acids are considered more anti-inflammatory. And the omega-6 pathway starts with LA, linoleic acid. Again, that's the essential omega-6 fatty acid. And linoleic acid can be used to make other omega-6 fatty acids, such as arachidonic acid. ALA, or alpha-linolenic acid, again, that's the essential omega-3 fatty acid. It can be used to generate other omega-3 fatty acids, such as EPA and DHA. However, the conversion rate is really poor in the body, generating EPA and DHA from ALA. So that's why it's recommended to consume fish at least 2 times per week, as the fish food items will already have EPA and DHA in them. Someone consumes the fish items, obtain EPA and DHA, and bypass that poor conversion rate in the body of ALA to EPA and DHA. You'll notice these pathways utilize the same enzymes, therefore it's not recommended to consume high amounts of omega-6 polyunsaturated fatty acids that'll interfere with the production of the omega-3 fatty acids. My graduate student in her master's thesis demonstrated that Americans do not meet the recommendations for EPA and DHA, omega-3 fatty acids. Americans typically consume fish about 2 times per month, as opposed to the recommendation of 2 times per week. And focusing on the upper panel here in this figure, it shows isochloric substitution of saturated fatty acids by equivalent energy from these items here, and then percent changes in risk of coronary heart disease at the bottom here. So increase the risk for heart disease or decrease the risk for heart disease. So isochloric substitution of saturated fatty acids by equivalent energy from trans fat, that increases the risk for coronary heart disease. Substitution of saturated fatty acids with MUFAs or monounsaturated fatty acids decreases the risk for coronary heart disease, and substitution of saturated fatty acids with polyunsaturated fatty acids or PUFAs significantly decreases the risk for coronary heart disease. And substitution of saturated fatty acids with carbohydrates from refined starches and sugars slightly increases the risk for heart disease. And substitution of saturated fatty acids with carbohydrates from whole grains decreases the risk for coronary heart disease. So this figure really illustrates the importance of consuming the polyunsaturated fatty acids such as the omega-3 and omega-6 PUFAs to decrease the risk for coronary heart disease. And this figure on the x-axis shows increment of energy from specific type of fat in percentage versus change in total mortality in percentage or death. So increasing the consumption of trans fat and saturated fat increases the risk of death, whereas consuming monounsaturated and polyunsaturated fats decreases the risk for death, especially polyunsaturated fats. And this figure is a summary or meta-analysis of prospective cohort studies. On the x-axis shows linoleic acid as a percentage of total energy intake, and the y-axis shows relative risk of total coronary heart disease events. So focusing on the green line, as someone increases the consumption of linoleic acid, there's a decreased risk of total coronary heart disease events, such as a heart attack or a stroke. Again, emphasizing the importance of consuming linoleic acid, which is the essential omega-6 PUFA. And this figure shows the diet-heart hypothesis. I have a question mark here, as I'll cover this towards the end of the presentation. And the diet-heart hypothesis suggests that consuming saturated fatty acids increases LDL cholesterol, which increases the risk for heart disease. This is a blood vessel here. These are endothelial cells that line blood vessels. There's a blood vessel lumen here. So LDL particles may enter into the intima and become oxidized by free radicals. Oxidized LDL particles signal monocytes to migrate into the intima, where they differentiate into macrophages and take up these oxidized LDL particles and eventually become foam cells, which are rich in lipids. And these foam cells may form plaques, which can narrow the lumen of blood vessels. And a blockage can cause a heart attack or stroke. And factors that increase the risks for cardiovascular disease include high blood pressure, inflammation, oxidative stress, family history, genetics, cigarette smoking, obesity, overall dietary patterns, which I'll cover later. And lipid levels are strong risk factors for cardiovascular disease, including high total cholesterol, high triglycerides, high LDL cholesterol, high VLDL cholesterol, and low high density lipoprotein cholesterol, HDL cholesterol. And this figure summarizes lipoprotein metabolism. So we consume fats and lipids in a meal, and these lipids and fats are incorporated into chylomicrons inside intestinal cells. They enter the lymphatic system and eventually the bloodstream, where these chylomicrons deliver dietary lipids to body cells such as muscle and fat cells, adipocytes. Then as cells remove lipids from the chylomicron, they become smaller chylomicron remnants, and the liver cells remove these chylomicron remnants from the bloodstream. And liver cells may form VLDL particles, which deliver lipids to body cells such as muscle and adipose tissue. As these cells remove lipids or fatty acids from the VLDL, they form smaller LDL particles, which are rich in cholesterol. And LDL deliver lipids to body cells or return to the liver. And liver cells may also generate HDL particles, which pick up cholesterol from body cells and deliver cholesterol to the liver for excretion. Therefore, HDL is considered the quote-unquote good cholesterol. This refers to their function. HDL particles are removing cholesterol. It's not a different type of cholesterol. And LDL particles considered the bad cholesterol. They just are rich in cholesterol. They do not contain a different type of cholesterol. It just refers to they have a high percentage of cholesterol, which can become oxidized and lead to the formation of the plaques that we previously covered. The objectives of the review article was to review human intervention trials that investigated the effects of LA or linoleic acid consumption on lipid risk markers for CVD in healthy individuals, such as total cholesterol, triglycerides, LDL cholesterol, VLDL cholesterol, and HDL cholesterol, provide mechanistic details, and suggest linoleic acid recommendations to decrease lipid risk markers for cardiovascular disease. So brief methods. PubMed was used to search for peer-reviewed journal articles using various search words such as linoleic acid, omega-6, human clinical trial, cholesterol, VLDL, LDL, HDL, triglycerides, and so on. Inclusion criteria. Journal articles contain information on linoleic acid consumption, such as grams or percentage energy on lipid risk markers. The authors stated that the individuals were healthy. There were no age restrictions. However, these were all adults in these studies. Intervention trials were at least 1 week in length. Exclusion criteria, amount of linoleic acid consumed was not stated. The authors did not indicate that the subjects were healthy. Postprandial and animal studies were also excluded. Using these criteria, 16 journal articles were found. And I'll summarize the results. So the main findings from their review: consumption of linoleic acid decreased total cholesterol compared to diets that were not rich in PUFA, such as diets rich in saturated fats. Consumption of linoleic acid generated mixed results on triglyceride concentrations, whereas intakes of EPA and DHA more consistently decreased triglycerides, emphasizing the importance of consuming fish. Consumption of linoleic acid decreased LDL cholesterol compared to diets rich in saturated fatty acids. However, there were inconsistent results compared to oleic acid, which is the common dietary monounsaturated fatty acid that we mentioned earlier. And consumption of linoleic acid reduced VLDL cholesterol compared to oleic acid. Intake of a saturated fatty acid or linoleic acid-rich diet, both supplemented with EPA and DHA, also decreased VLDL cholesterol, again emphasizing the importance of consuming fish. Consumption of linoleic acid decreased HDL cholesterol compared to palmitic acid, which is a common saturated fatty acid in the diet, or EPA and DHA, again emphasizing the importance of consuming fish. And also it's important to note here that saturated fat tends to increase the good HDL cholesterol. And there are no differences compared to oleic acid. In many studies, there were no differences or mixed results when comparing linoleic acid and oleic acid intake. Some more research needs to be done in this area. And discussion, I'll be covering the mechanisms by which linoleic acid affects these lipid risk markers. So this is the liver here. Mechanisms by which PUFAs or linoleic acid reduce total cholesterol. They increase the liver X receptor, which increases CYP7 enzyme, which increases the conversion of cholesterol to bile acids, thereby increasing cholesterol catabolism. Mechanisms by which PUFAs decrease triglycerides. So lipoprotein lipase, or LPL, is more reactive to VLDL with PUFA triglycerides. So lipoprotein lipase, or LPL, is on the surface of muscle and adipose tissue, and it's more reactive to VLDL particles that contain PUFA triglycerides, thereby increasing the catabolism of these triglycerides. And PUFAs, such as linoleic acid, reduce ApoC3, which is an apolipoprotein on the surface of VLDL particles. ApoC3 inhibits LPL activity. Therefore, by decreasing ApoC3, it increases LPL activity, thereby increasing VLDL triglyceride catabolism. Mechanisms by which PUFAs decrease LDL cholesterol. This is a liver cell here. It's the bloodstream. So these PUFAs will increase membrane fluidity. So phospholipids in cell membranes that contain Polyunsaturated fatty acids will have kinks around the double bonds, and that increases membrane fluidity, which increases LDL receptor activity. And these LDL receptors will bind to LDL particles shown here. So there's increase in LDL binding to the LDL receptors, which increases internalization of these LDL particles and eventually increases LDL catabolism in the liver, thereby removing these LDL particles from the bloodstream. The mechanisms by which PUFAs decrease VLDL cholesterol, they decrease the SREBP1. So the SREBP1 is involved in forming these VLDL particles in the liver. Therefore, by decreasing SREBP1, this leads to decreased VLDL secretion. And the mechanisms by which PUFAs impact HDL cholesterol, they increase ApoA1, which is an lipoprotein on HDL particles. Therefore, by increasing ApoA1, it increases HDL cholesterol. However, saturated fat tends to significantly increase HDL cholesterol, so definitely more research needs to be done in this area. So fat recommendations to reduce cardiovascular disease risk shows food sources of linoleic acid that we covered earlier, which include various oils, nuts, and seeds. So serving sizes here and the amount of linoleic acid in these food sources. The adequate intake, or AI, for adults 19 to 50 years is 12 grams per day for females and 17 grams per day for males, whereas the AI for adults 51 years and older is 11 grams per day for females and 14 grams per day for males. Therefore, if someone just consumes a couple servings of these food sources, they will likely achieve the linoleic acid recommendation for the day. The American Heart Association recommendations for linoleic acid: 5 to 10% of energy to decrease the risk for CVD. The World Health Organization recommendations for linoleic acid: 2.5 to 9% of energy to decrease the risk for CVD. And it's recommended to replace a portion of saturated fatty acids with MUFAs and PUFAs and include 5 to 10% of energy as linoleic acid to reduce the risk for CVD. However, the types of dietary fatty acids rather than total amount is most important for reducing CVD risk. It's recommended to emphasize whole foods and overall dietary patterns, which I'll discuss here shortly. So the American College of Cardiology, American Heart Association recommendations to reduce CVD risk: consumption of adequate amounts of fruits, vegetables, whole grains, legumes, beans, nuts, lean vegetable and animal protein sources, and fish. Reduce the intakes of trans fatty acids, red meats, processed red meats, refined carbohydrates, cholesterol, sodium, sugar-sweetened beverages, and replace a portion of saturated fatty acids with monounsaturated and polyunsaturated fatty acids. The dietary guidelines for Americans to reduce CVD risk: use vegetable oils in place of sources high in saturated fat, such as lard, coconut oil, palm kernel oil, palm oil, butter, high-fat meats, full-fat dairy products. Limit the intake of saturated fats to less than 10% of energy by replacing them with unsaturated fats, especially polyunsaturated fats. However, I'm not sure the general public will understand these recommendations. Food sources are not provided here. It's also important to consider fats versus overall dietary patterns. The World Health Organization recommendations to reduce CVD risk: total fat intake should not exceed 30% of energy, with less than 10% of energy as saturated fat. Trans fat consumption should be less than 1% of energy, and replace saturated fats with unsaturated fats such as fish, avocado, nuts, and safflower, sunflower, corn, soybean, olive, and canola oil. So it's nice that they included some food sources here. However, again, it's important to consider fats versus overall dietary patterns. Someone could consume a plant-based diet, such as the Mediterranean diet, that's rich in fruits, vegetables, whole grains, nuts, seeds, beans, fiber, and phytochemicals, and it may partially offset any negative effects of the fatty acids on CVD risk markers. This is the diet heart hypothesis that I mentioned earlier in the presentation. It began in the 1950s. The original hypothesis stated that consumption of dietary fat increases blood cholesterol, which increases the risk for coronary heart disease. This evolved to recommend reducing saturated fat and increasing polyunsaturated fat, as blood cholesterol is in various fractions, such as LDL and HDL particles that we covered earlier, which can affect coronary heart disease risk. For example, high LDL cholesterol increases CVD risk. And this has evolved to our current understanding that we should focus on foods and overall dietary patterns, as LDL cholesterol is just a single lipid risk marker. There are many other lipid risk markers. There's HDL cholesterol, non-HDL cholesterol, cholesterol to HDL cholesterol ratio, triglycerides, apolipoproteins, LDL size. So the smaller LDL particles are more atherogenic, and these may be caused by a high consumption of carbohydrates, low consumption of fat. And there are non-lipid risk markers for CVD, including high blood pressure, thrombosis, cardiac arrhythmias, endothelial dysfunction, inflammation, oxidative stress, microbiome in the intestines. So much more research is needed on the effects of these risk markers on coronary heart disease risk. And also, again, if someone consumes a plant-based diet, it's rich in fruits, vegetables, whole grain, nuts, seeds, beans, fiber, phytochemicals, and it may partially offset the negative effects of fatty acids on CVD risk. So the authors of this article recommend shifting from saturated fatty acid-based to food-based dietary guidelines for cardiovascular health. The previous advice was to restrict saturated fatty acid intake to reduce risk of cardiovascular disease. The current evidence-based health effects of saturated fatty acids depend on the interacting effects from naturally occurring food components and from unhealthy compounds introduced by processing. For example, whole-fat dairy products, unprocessed red meat, and dark chocolate contain complex food matrices with high saturated fatty acid content, but also other nutrients and non-nutritive components such as proteins, vitamins and minerals, phospholipids, probiotics, phytochemicals, and certain studies suggest that these food items do not increase the risk for CVD. Therefore, new recommendations should emphasize food-based strategies that translate for the public into understandable, consistent, and robust recommendations for healthy dietary patterns. And I created this image that was published in a book chapter. So there are saturated, monounsaturated, and polyunsaturated fatty acids that display different individual effects on lipid risk markers for cardiovascular disease. However, whole foods and overall dietary patterns contain a variety of fatty acids. Whole foods and overall dietary patterns also contain macro and micronutrients, fiber, phytochemicals, and probiotics. And this may lead to changes of individual fatty acids on lipid risk markers for cardiovascular disease. For example, someone consume a plant-based diet rich in fruits, vegetables, whole grain, nuts, seeds, beans, fiber, and phytochemicals, and it may partially offset any negative effects of fatty acids on CVD risk. So future studies should look at mechanistic studies on fatty acids and how they impact CVD risk. Study refined versus whole carbohydrate diets on CVD risk, high versus low carbohydrate diets, high versus low fat diets, types and amounts of fats, plant-based versus meat-based diets on CVD risk, linoleic acid versus other fatty acids, and linoleic acid on lipid risk markers for cardiovascular disease. So much more research needs to be done in these areas, how they impact CVD risk. So this article appears in the journal Nutrients. I published this along with my colleague, Dr. Bonnie Burns-Whitmer, so feel free to access this article if you want to find more information on this topic. So hopefully we can all obtain the recommendation for linoleic acid by consuming nuts, seeds, and oils throughout the day. Also be helpful to consume a plant-based diet, such as the Mediterranean diet, that's rich in fruits, vegetables, whole grains, nuts, seeds, beans, fiber, and phytochemicals, and also fish at least 2 times per week to obtain the EPA and DHA omega-3 fatty acids. So thank you for attending my presentation. You can also send me an email if you have any questions, and I really appreciate your support. And again, thank you, everyone. Have a great week.
Thank you for that excellent presentation. If there are any questions now.
In El Bolsón, a little town in the Argentine Patagonia. And I want to share with you something that I think is so important in the time that we are looking for the technology advances in this topic that it takes with the agriculture. We can make a step back to have more strength to jump forward. Agriculture is a major source of pollution and greenhouse gases, and the industrial agriculture can make soil, water, and air pollution, and it can produce pollution-related disease, and we must think new strategies to mitigate the pollution effects. In this non-systematic review on agricultural-related pollution effects in the cardiovascular system and interventions to mitigate emissions to reduce morbidity and mortality, and the focus is made in air pollution and cardiovascular effects. Like secondary goals, I show you some forms, other forms of pollution and involvement of other organs of the body. The three topics that I want to share with you are sources of agricultural-related pollutants resulting in cardiovascular diseases, and then to think strategies to mitigate these effects. The sources of agriculture-related pollutants mainly may be burning of agricultural residues, tillage and soil erosion, use of pesticides and synthetic fertilizers, emissions generated by intensive livestock farming, and agricultural machinery fossil fuel dependency. One of the most important pollutants related to the agriculture work is the ammonia. 81 of the global ammonia emissions come from agriculture, and it is produced by livestock digestion and manure management and the use of synthetic fertilizers rich in nitrogen. The direct effects is the irritation of the respiratory tract and mucous membranes that it was seen in rural workers mainly, and the indirect effects is the formation of fine particulate matter. It occurs in two steps. First, the volatilization and dispersion of the ammonia, and then the interaction with atmospheric acids that they make ammonium sulfate, ammonium nitrate, and ammonium chloride that are components of the fine particulate matter. The second one is particulate matter less than 2.5 micrometers. It may be primary or secondary. Secondary is when it is made in the atmosphere. It enters through the respiratory tract, and first at lung level, it produces first step oxidative stress, and then by chemical mediators or the passage of material into the bloodstream, in the vascular bed, it produces oxidative stress, vascular inflammation, and prothrombotic factor activation. The final way of all these processes is it result in acute vascular syndromes like stroke or coronary acute syndromes and the progression of atherosclerosis. Another pollutant are the pesticides. They can be in the water, in the soil, and the air. The forms of contamination may be accidental, occupational, or overconsumption, and they can produce volatile organic compounds that became in tropospheric ozone in the atmosphere and produce cardiovascular and respiratory tract damage. At the vascular system may produce endocrine disruption and cardiac arrhythmia, and it can have other effects in the like cancer, allergies, dermatitis, liver damage, asthma, peripheral neuropathy, and teratogenesis. It can produce greenhouse gases. The methane is produced by enteric fermentation and manure handling. The machinery with fossil fuel dependency can produce some pollutants. The more important for the GHGs is the CO2, and the nitrogen-rich fertilizer are responsible of the production of nitrogen dioxide. 26 to 31% of GHGs come from agriculture and the food production chain, and it is projected to increase in 10% by the year 2030. It's important to know that the methane has 25 times more powerful, and the nitrogen dioxide 300 times more powerful to produce greenhouse gases like the more than the CO2. There is a very strong and close relationship between GHGs and air pollution. The rising temperatures and extreme climatic events may add their action to air pollution to produce cardiovascular disease. And what can we do with this topic? The first intervention we propose is to change conventional agricultural practices. The objective is to maintain productivity, avoiding soil degradation, and reducing the emission of pollutants and GHGs. The FAO is fostering conservation agriculture. It includes minimal mechanical soil disturbance, permanent vegetation cover, and species diversification. And the focus is made in the agroecology method. The minimal mechanical disturbance of the soil, it may be produced by zero-till or minimum tillage, direct seed and fertilizer placement, and it benefits crops and prevent degradation by soil erosion reduction, avoid moisture loss, and organic matter preservation. And the benefits of in the air pollution is the reduction of nitrogen dioxide emission, CO2 release, and energy use. The second strategy is the permanent vegetation cover. It uses crop residues or cover crops, and it is a protective layer of vegetation on the soil, suppressing weeds. It protects the soil against erosion, retains moisture, and prevents compaction of the soil. The reduction in air pollution is made by airborne dust reduction and particulate matter volatilization, and it reduces the use of energy. The third idea is to make species diversification. It is made by crop rotation and multifunctional landscapes. It promotes diversity of soil, flora and fauna, improves plant nutrition, and helps prevent pests. The benefit on the reduction of air pollution is reducing GHG production, primarily the nitrogen dioxide. And when we talk about agroecology focus, you must think in the mixture of sciences, social movement like solidarity, regionality and food sovereignty, and productive practice, some of them from the traditional and aboriginal usage. The agroecology focus make promotion of family and community food production, the regional produce and consumption, sustainable food usage, and misuse of agrochemicals and synthetic fertilizers. The benefits for the health, for the human health, is the reduction of pesticides expositions, and like it was shown in Malaysian study, the conventional crop workers and their communities increased blood pressure, and they had higher fasting blood glucose than agroecology workers. And it is very important that those who produce agroecological food adopt healthier diets with higher vegetable contents. This is the nutrient Santé study that was very, very important. More than 60,000 people participate in this study, and with almost 10 years of follow-up. And it shows that the people who consume more organic foods have less cardiovascular risk factors like obesity, diabetes and high blood pressure, metabolic syndrome, and less non-communicable disease. Cardiovascular disease, most important was stroke outcome, and some cancers and pregnancy-related illnesses. All of this was less in the organic consumption than the people that eat conventional products. I want to show you this work in our schools in the little town where I live. This is a urban school with children working in an agroecological vegetable garden. You can see their shining and smiling faces, and well, they were working in the ground, making their vegetable garden and taking their own food. The second intervention is to mitigate pollution from agricultural machinery and burning. We can use for all of these pollutants control measures like particulate matter filters, emission control system, equipment that use biodiesel and electricity. And it's very important the regionalization of consumption to reduce the transport and the release of pollutants. And for the burning, we propose the composting and chipping of biological waste. The third is a plant-based diet, reducing meat consumption and moving towards a plant-rich diet. We can reduce mortality from food production by 40%. Those who consume healthier, another time, and vegetable-rich diets suffer less than the effects of air pollution. It was shown in UK Biobank study, a very big study with more than 500,000 participants. In conclusion, the industrialized agricultural practices and the source of environment, the source of environmental pollutants and GHGs, agriculture-related pollution and GHGs will induce cardiovascular disease. There are a number of practices that can reduce pollution levels without reducing productivity. Increasing vegetable consumption could reduce pollution and greenhouse gas emissions, And at the end of the day, we encourage people to shift to an agroecological lifestyle as a healthy habit. And with this picture of our children at the side of their vegetable garden by agroecology focus, their work all this time, I thank you for your attention.
Thank you for that excellent presentation. If anyone has any questions, now would be the time.
And today my topic will be atrioventricular nodal reentrant tachycardia, clinical and electrocardiographic challenges, a case series and literature review. I have no conflicts of interest to disclose. Here's the outline I will be following. AVNRT is a paroxysmal SVT, and it represents 90% of paroxysmal SVTs. Its prevalence in the general population is 0.2%. It's a low prevalence. The substrate is dual atrioventricular nodal physiology. This model schematically suggests that within the AV node, there are two conduction pathways: a slow pathway with slow conduction velocity and short refractory period, and a fast pathway with fast conduction velocity and long refractory period. In the case of a short coupled atrial premature beat, the impulse is blocked in the fast pathway due to its long refractory period. Consequently, it is conducted to the His bundle via the slow pathway. Subsequently, the impulse may be conducted retrogradely through the fast pathway. This can result in atrial echo beat or in a reentrant tachycardia. This circuit, as described, is the circuit of typical slow-fast AVNRT. There are other types of AVNRTs known as atypical AVNRTs, fast-slow, slow-slow, etc. The long-term management can be pharmacological based on calcium channel blockers or beta blockers, but the definitive and curative treatment is slow pathway ablation. The technique most commonly used is radiofrequency ablation. Cryoablation is another option. The objectives of my study are to describe epidemiological, clinical, and electrocardiographic features of AVNRT, and to compare AVNRT with other types of paroxysmal SVTs. Every cardiologist is familiar with AVNRT. The aim of my presentation is to emphasize a few overlooked points that could potentially change our clinical practice. I will focus on three key points: the epidemiological profile of patients, some diagnostic challenges, and how to identify patients who would benefit most from electrophysiological testing, and some electrocardiographic features. My study is a retrospective, descriptive, and analytic study conducted in a single center, the Department of Cardiac Electrophysiology in the Mohammed V Military Hospital in Rabat. It was conducted from January 1st, 2018 to December 31st, 2022, and included 62 patients. The patients were selected according to the following inclusion criteria. The tachycardia had to be documented on an ECG, an ECG Holter, or an electrophysiological study, and the patient must have undergone an electrophysiological study. We included patients with an ECG consistent with AVNRT, where the EPS excluded an accessory pathway and demonstrated dual AV nodal physiology. Were excluded patients who reported palpitations without documented tachycardia, patients who did not undergo electrophysiological study, and patients in whom the EPS revealed accessory pathway. I will now summarize the results. Regarding the epidemiological characteristics of our patients, the average age of hospitalized patients was 48 plus or minus 13 years. We observed that 90% of the patients were aged between 30 and 69. We also studied the age at symptoms onset. The average age was 40 plus or minus 15 years. And we noticed that 28% of our patients reported symptom onset after the age of 50. we observed a clear female predominance in this population. Women represented 56% of the cases. Regarding tachycardia documentation, the duration of symptoms before SVT documentation ranged from 4 months to 60 years, with a median at 4 years. Tachycardia was documented in 80% of the cases on a per-episode ECG. What it means is that some patients experience palpitation for years before the diagnosis of SVT, and the diagnosis was made only during an emergency consult. In 17% of the cases, the tachycardia was triggered during an electrophysiological study. These are well-selected patients. They were selected for electrophysiological testing based on their symptoms. Finally, in 1.6% of the cases, the tachycardia was documented on an ECG Holter. We can see that ECG Holter has a very low diagnostic performance. The symptoms during episodes of SVT were largely dominated by palpitations, reported in 98% of the cases. Other symptoms included presyncope, dizziness, autonomic dysfunction, dyspnea, chest tightness, and other neurosensory symptoms. Regarding ECG features, AV-nRT is typically a regular narrow QRS tachycardia. However, the QRS complexes can be wide in cases of pre-existing or functional conduction block. In our series, 29% of the patients had wide complex tachycardia. The analysis of atrial activity in regular narrow QRS tachycardias is essential for etiological diagnosis. In our series, P-wave were not visualized in 12% of the cases. When they were visible, we analyzed the RP interval. It was short, meaning less than 90 milliseconds in 74% of the cases. When the RP interval was short, we noticed patterns like pseudo-S waves in the inferior leads or pseudo-R prime wave in lead V1. Whenever the P waves are not visible or when the RP interval is short, it strongly suggests typical AV-nRT. This is due to retrograde atrial activation via the fast pathway, making it almost simultaneous with ventricular depolarization. In our series, typical AV-nRT accounted for the vast majority of the cases, 88%. Here is an example of an ECG. It shows a narrow QRS tachycardia at approximately 130 beats per minute. When assessing atrial activity, we can see a small negative wave in the inferior leads that is very close to the QRS complex. Here it is. It gives the appearance of a pseudo-S wave. And when we compare to the ECG in sinus rhythm, we can notice that this wave disappears, confirming that it was indeed a retrograde P wave. I'll now discuss the results. In our series, the mean age was 48 plus or minus 13 years, which aligns with the data from the literature. This is a graph from Porter and colleagues showing the proportion of different paroxysmal SVTs by age group. In black, it's atrial tachycardia, in gray, it's AV-nRT, and in white, it's atrioventricular reentrant tachycardia, orthodromic or antidromic. We noticed that the proportion of patients with AV-nRT is high across all age groups, and it increases with age. Contrary to AV-RT, that decreases with age and seems to affect mainly young patients. That's the first point. The second point is the late onset of symptoms. Erdogan and colleagues made the same observation as us. In their series, 23% of the patients reported symptom onset after the age of 50. The takeaway from this is that AV-nRT does not exclusively affect young patients. In the literature, there was also a clear female predominance, women representing 60 to 70% of the cases. The symptoms reported in the literature were once again largely dominated by palpitation. Dyspnea, chest pain, syncope, and presyncope were also reported, and up to 80% of the patients reported atypical symptoms. So let's consider a situation that is not uncommon in clinical practice. This is a hypothetical patient. Her name is Miss M. She's 33 years old. She has been experiencing symptoms for 2 years, palpitations 1 to 2 times per month with paresthesia. During the consult, the clinical examination is unremarkable, and the ECG, here it is normal. In this situation, should we simply advise her to stop drinking coffee and ensure good sleep? Should we immediately perform an EPS? Or should we opt for an ECG Holter, given that her episodes occur only 1 to 2 times per month? The likelihood of capturing an arrhythmia with an ECG Holter is very low. This situation is problematic and occurs very frequently. And this issue has been highlighted in the literature. How can we distinguish the symptoms of paroxysmal SVT from those of psychogenic causes like anxiety, etc.? The problem was encountered by our patients. 8% of our patients received magnesium or anxiolytics for years before the diagnosis of SVT. This is an American paper published on this subject, including AVNRT and AVRT. In the paper, they report that more than half of the cases, 54%, symptoms were attributed to panic disorder or anxiety. And women were twice more likely to have their symptoms attributed to a psychogenic cause compared to men, 65% versus 32%. So what's the solution to this problem? First, we could better characterize the palpitations. Specifically, we can ask about neck palpitations. They are reported in 50% of the cases and are strongly associated with typical AVNRT. To understand the pathophysiology of this observation, we should go back to the ECG. In the ECG of a typical AVNRT, the P wave occurs before the T wave, meaning that atrial depolarization occurs before ventricular repolarization. This means that atrial systole occurs against closed atrioventricular valve, leading to blood reflux to the peripheral venous system, including the superior vena cava and the jugular veins. This sign is described in the literature as frog sign by Contreras, Valdez and colleagues, neck pounding and shirt flapping by Laurent and colleagues. Beyond its value for positive diagnosis, it's also useful for differential diagnosis with other types of SVTs. In fact, it's much more frequently described in AVNRT for the reasons mentioned earlier. These symptoms are included in the latest guidelines of SVTs of the European Society of Cardiology of 2019 and the American Heart Association of 2015. However, in our series, the question was not asked to the patient. It would be beneficial to develop the habit of asking about this kind of symptoms. This is a video to see how it looks like. Another interesting clinical aspect regards post-episode symptoms, particularly polyuria that is reported in 20 to 50% of the cases in the literature. The prevalence of polyuria in our series could not be determined because, once again, the patients were not systematically asked about this. Once again, this highlights another area of improvement in our patients' interview process. Finally, recent technological advances can also be valuable in helping document tachycardia. Smartwatches immediately come to mind. Several cases have already been reported in the literature where a smartwatch enabled the diagnosis of AVNRT. The main difficulty lies in the diagnosis of AVNRT. Once the diagnosis is made, management becomes much simpler. The rationale is based on the risk-benefit balance. Our goal is to prevent the patient from experiencing further episodes of SVT, and our main concern is the primary risk of the ablation procedure, which is AV block. According to the ESC guidelines for symptomatic recurrent episodes of SVT, catheter ablation is indicated. It is performed on the slow pathway. It has a very high success rate of 97 to 100%. However, we noticed in our series a lower success rate for atypical AVNRT. This is also the observation made by Feldman and colleagues. The atypical nature of AVNRT was the only independent predictor of procedure failure. The main complication of the ablation procedure for AV and RT is atrioventricular block. In our series, 2 patients developed transient AV block during the procedure, but no patient required pacemaker implantation. This complication is also very rare in the literature, occurring in less than 2%. It's a rare complication with slow pathway ablation, which is much safer than fast pathway ablation. In fact, in the literature, the studies that included patients who benefited from fast pathway ablation reported higher rates of AV block, necessitating pacemaker implantation, reaching up to 5%. Finally, here are some take-home messages. AV and RT, atrioventricular nodal reentrant tachycardia, is a paroxysmal SVT. It's a reentrant tachycardia, and the substrate is dual atrioventricular nodal pathways. Typical AV and RT slow-fast represents the vast majority of AV and RTs. It affects middle-aged adults. A late onset after the age of 50 is possible. It predominantly affects women. The symptoms are largely dominated by palpitations. The treatment is slow pathway ablation. It's effective and safe. The complications are rare, and the main complication is AV block. There's a problem with tachycardia documentation and diagnostic delay with AV and RT. Here are some possible improvements. First, regarding history taking. We should listen to patients and avoid concluding too easily that symptoms are of psychogenic cause, especially in the cases of women. We should ask better questions, like palpitations felt in the neck, polyuria. And we should utilize technology, particularly smartwatches, for ECG recording. All of this aims to select the patients that would benefit most from electrophysiological testing, all of this to reduce the diagnostic delay. Thank you for your attention.
Thank you for that excellent presentation. If anyone has any questions, now would be the time.
Treatment of patients with cardiac myxomas from Mosov National Institute of Cardiovascular Surgery of the Academy of Medical Science of Ukraine, Kiev. Next slide, please. The relevance of the term is first, the frequency of diagnosis of primary heart tumors, of which more than 80% are morphologically benign tumors, which range from 0.09 to 1.9% of total number of hospitalized patients. Second, in hospital mortality was from 1.3 to 3% in a myxoma group. Third, the number of cardiac myxomas per year for Ukraine can be near 100 cases. Fourth, absolutely unfavorable prognosis without surgery. With primary heart tumors without surgery, 90% of patients die up to 12 months from the date of diagnosis. And fifth, the issue of diagnosis, differential diagnosis and surgical interventional method aimed at radicalizing the operation and preventing the recurrence of the tumor. Next slide, please. Please, next slide. The aim of the study was to search the tactic of optimal and safe surgical treatment of patients with cardiac myxoma. Next slide, please. In our institute, Mosov Institute, we can see quantity and structure of primary heart tumors from 1969 to 2025. The 1,046 interventions were performed in heart tumors, from which cardiac myxomas most over was in 88.4%, non-myxomas benign primary heart tumors 3.9%, and malignant primary heart tumors was 6.8%. Next slide, please. This slide we can see cardiac myxoma localization, and most of over was localization cardiac myxomas in left atrium in 88.1%. In the right atrium, there were 8.9%, right and left ventricle 0.9% secondly, and multiply localization cardiac myxomas was 1.3%. Next slide, please. On this slide, we can see anatomical peculiarities of cardiac myxomas according to the echocardiography data. First, there were a porous character of neoplasm with uneven contour, which are changing in the process of the movement in the 74.7%. And second, the solid neoplasm with even smooth edges formed by a capsule in 25.3%. Next slide, please. In this slide, we can see proportion of left atrium myxomas penetration into the left ventricle according to the echocardiography data. First, there were mobile heart myxomas penetrating into the left ventricle cavity. There were 93.6%. Next, the less mobile heart myxomas with which occupied whole left atrium and penetrate into the mitral valve orifice, 0.9%. And third, the mobile heart myxomas which are not penetrated into the left ventricle cavity, it's 5.5%. Next slide, please. On this slide, we can see localization of the base of left atrium myxomas or at the interarterial septum. There were 124 patients. The first localization of base of cardiac myxomas was fossa oval fossa and zone around it, 53.2%. And the second, the middle third of the interarterial septum, so 36.3%. And the third, the upper third of the interarterial septum, there were 10.5%. Next slide, please. And we propose the improved methods of exit of the right atrium and interarterial septum for removal left atrium myxoma. We can see incisions near the ostium of right pulmonary vein, and we can see the base in this base of cardiac myxomas. Next slide, please. And the frequency of damage of the base of left atrium myxoma with application of the optimal methods of dissection of interarterial septum. In the 193 patients, there were first without damage of the myxoma base, there were 97.9%, and with the damage of myxoma base, there was 2.1%. Next slide, please. On this slide, we can see features of the macrostructure of myxoma in patients with mechanical valve damage in 22 cases. The first is the large cluster-shaped cardiac myxomas without calcium inclusion. It's 3 cases, and most of all, there were second, the cluster-shaped with massive areas of fibrosis and calcification, 18 cases, and avoid inactive cardiac myxoma with calcification on the distal surface in 1 case. Next slide, please. And we can see additional surgical procedures other than removal of cardiac myxomas. In there were repair of mitral valve of 2 and 0.9%, repair of aortic valve, tricuspid valve, most of all 4.1%, replacement of mitral valve, tricuspid valve, aortic valve, and aortic and plus mitral valve, and the cardio-aortic bypass grafting. Next slide, please. And our mortality dynamic in cardiac myxoma removal last 25 years in more than 175 operations, we have zero mortality. Next slide, please. And summary. First, the urgent surgical intervention directed to maximum completed tumors removal is only the effective method of cardiac myxomas treatment. Second, cardiac myxomas removal requires implementation of certain surgical principle and technical maneuvers for prophylaxis of tumor fragmentation during its removal with the possible subsequent embolism. And third, strict adherence to main principle of cardiac myxoma surgical treatment permit to decrease the risk of surgical intervention to the maximum extent. Next slide, please. Thank you very much for the attention.
That was an excellent presentation. Thank you. Please put your name and email into the chat box. And okay, and we will move on to our next poster by Dr. Olgovna, lipid-lowering therapy and dyslipidemia in patients with acute coronary syndrome of 14. All right, thank you for the lovely poster. This will conclude our session for today. We hope all you would have had a great time in this event, and we do hope that you'll carry a whole lot of memories with you to be cherished forever. We've come to the end of the event at this time, and we would like to
Good morning to one and all. I am Dr. Varda Hassanis. I am senior gynecologist from KIMS Medical College, Andhra Pradesh, India. Today we are here as a team of gynecologists. We give our thanks to organizers of 3rd International Conference of Cardiology and Cardiovascular Research. We are here today to present a rare case of vulval mass which we have operated, and the histopathology report has come as angiofibroblastoma. It is a very rare tumor of vulva. Now I hand over this session to my junior Dr. Rama for presentation of the case. Thank you.
So good morning all, this is Dr. Rama, junior resident from KIMS Medical College. Now I am going to present the case report, angiomyofibroblastoma. Coming to introduction, it is a rare benign mesenchymal tumor that is composed of fibroblastic, myofibroblastic and vascular elements from which the term was derived. The term was first coined in 1998 by Fletcher et al. Due to its distinctive features that resemble both fibroblastic and smooth muscle differentiation. It accounts for less than 1% of all vulval tumors. Most cases occur in women of reproductive age, typically between 30 to 60 years. Most frequent site is in the vulva, which accounts for approximately 70% of the cases, but can also occur in other parts of the body like vagina, perineum, deep soft tissues and retroperitoneum. Rarely it occurs in males in the inguinal-scrotal region, scrotum and the spermatic cord. Coming to clinical presentation, the most common presentation is a painless swelling which is often found incidentally during physical examination. Symptoms include swelling, discomfort or a palpable mass, particularly in the genital area. Larger lesions can cause pressure effects or other localized symptoms, but most of them are asymptomatic. It is a slow growth, painless, pedunculated, which is very rare and which got less tendency for recurrence and metastasis. It is a well circumscribed rubbery masses which range from 0.5 to 12 centimeter in size and which is characteristic pink coloration in the gross specimen. Due to their subtle presentation and non-specific clinical features, these are often misdiagnosed as Bartholin cyst and other benign mesenchymal tumors like lipoma and leiomyoma. Coming to histopathology, it is mainly diagnosed by histopathological examination, and the two major components are prominent blood vessels and stromal cells. Histopathological findings show abundant thin wall blood vessels with hypo and hypercellular areas, and these exhibit features similar to smooth muscle including eosinophilic cytoplasm and elongated spindle-shaped nuclei. Fibroblastic areas are characterized by bland spindle-shaped cells arranged in fascicles. The vascular component consists of small, thin wall capillary-like vessels which has a perivascular cuff of myofibroblastic cells. Immunohistochemistry, this plays a very essential role in confirming the diagnosis. These are usually positive for smooth muscle acting desmin and vimentin. Out of this, desmin and vimentin are strongly positive in angiomyofibroblastima and weak positivity for estrogen and progesterone receptor, negative for S100 and CD34. CD34 is usually positive in angiomyxoma. These are the various differential diagnoses. The most common, that is Bartholin cyst. Angiomyxoma compared to angiomyofibroblastima, these are usually locally infiltrative and aggressive. These locally invades the pelvic nerves and vessels. Spindle cell lipoma, in this spindle cells are the dominant cells and adipocytes are usually present. Cellular angiomyofibroma, this has a uniform cellularity. Leiomyoma, usually it contains a smooth muscle fascicles. Inguinal hernia and fibroepithelial stromal polyps, these are usually seen as polypoidal growth on HPE. Coming to management and prognosis, surgical excision is the treatment of choice as it is a benign tumor. Recurrence is rare, but complete excision is crucial to see that the tumor does not recur or cause complications. In case of small tumors, wait and watch may be considered. Prognosis is excellent after complete excision and the malignant transformation is extremely rare and recurrence rate is very low. Coming to the case report, we have reported a 47-year-old Paris woman who has come to our gynecological OPD with a complaint of swelling in the vulval region. It is first observed by the patient 13 years ago following trauma or vulval region due to slippage in washroom. The swelling was painless, gradually increased in size, and there were no complaints of pressure symptoms or any localized symptoms. She was hysterectomized 27 years back for abnormal uterine bleeding, and she has no other comorbidities. Family and medical history was not significant. Coming to a local examination of the vulva, there was a well circumscribed swelling of size 4 into 3 centimeters, which is pedunculated over lower 1/3 of the left labia majora, which is soft and elastic in consistency. There was no tenderness, no change in the skin color or temperature over the swelling. On pelvic examination, there were no palpable pelvic masses and the vault is intact, and there are no palpable inguinal lymph nodes. Upon examination, her vitals and systemic examination was normal. This is the preoperative images of the tumor, which is occupying the lower 1/3 of the labia majora, which is smooth and elastic in consistency, and there was no change in the skin color or there was no change in the temperature of the swelling. We have performed a transperineal ultrasound which showed a mass appeared solid, well demarcated vascularized lesion, hyperechoic areas with irregular and small hypoechoic cystic spaces which are scattered within homogeneous echogenic stroma. So we as a team planned out to excise the mass and send for histopathology. Patient was admitted and all routine investigations were done which are within normal limits. We have performed surgery under spinal anesthesia, and this is a gross specimen of the tumor. Surgical margins of the lesion were clear, and it is a 4 into 4 into 3 centimeter mass. There were no areas of hemorrhage or necrosis, and the specimen sent for histopathological examination. And the histopathology section showed a circumscribed tumor composed of spindle-shaped cells. This is the circumscribed unencapsulated tumor, and this showed hyper and hypocellular areas. Hyper is nothing but the stromal cells, and the hypocellularity is nothing but the edematous area, which is scattered of small veins in the myxedematous collagenous stroma. And these are the other specimen which showed a bland spindle and epithelioid to plasmacytoid tumor cells with eosinophilic cytoplasm, which are arranged in nest and cord-like pattern around blood vessels, and in between there are fat cells. And these are the binucleated and multinucleated stromal cells. Coming to postoperative follow-up, the patient came for follow-up to OPD 1 week after surgery. Her vital signs were normal and there was no evidence of bleeding or any infection at the surgical site. She was followed up after 3 months. Patient was well and asymptomatic, and this is the follow-up after 3 months PIC. Coming to discussion, angiomyofibroblastom is a rare benign tissue, soft tissue neoplasm that was first described by Fletcher et al. In 1992. He has performed a case series of 10 cases which are localized to vulva, and these predominantly affecting the vulvovaginal in the middle-aged women and rarely in male, which was done by Rocher et al. Biological behavior is generally indolent with a favorable clinical outcome for most of the patients. Sarcomatous transformation is exceedingly rare. Where in literature, there was 1 case reported of sarcomatous transformation, and recurrence is also very rare, where in literature only 2 cases have been reported. And the typical age at onset is 45 years, average age, and it's grows slowly from weeks to years, and it may take with no significant pain. And it is a rubbery mass, well circumscribed. It can grow up to 25 centimeters and histologically well demarcated, containing alternating hyper and hypercellular areas, and it contains adipocytes, which remarks the designation of the lipomatous variant in certain cases. And compared to angiomyxoma, which is similar to angiomyofibroblastima, they are locally infiltrative, whereas this is a well-defined borders with characteristic stromal cell clusters. And positive for vimentin and desmin, which is a strongly positive. Estrogen and progesterone receptor positivity suggests that it's a hormonal relation of the tumor. And the treatment is simple surgical excision with clear margins, which usually results in a favorable prognosis. So our case which we have presented, the patient underwent successful excision of the tumor, And case underscored the importance of recognizing it as a distinct and rare entity in the differential diagnosis of vulval masses, and the surgical excision remains the preferred treatment, with recurrence being uncommon when clear margins are achieved. This is the case we have reported. Now I hand over to my senior assistant professor. Will continue the presentation. Thank you.
Good morning all. This is Dr. Vasudha, Assistant Professor of KIMS at RF Medical College in Amlapuram, Andhra Pradesh. Hereby I conclude our case that it is a rare benign soft tissue tumor that primarily affects women, and it is typically found in vulvovaginal area. Despite its benign nature, early diagnosis and complete surgical excision are crucial to prevent recurrence and ensure a favorable outcome. The tumor's characteristic histopathology, including mixture of myofibroblastic cells, fibroblasts, and vascular elements, distinguishes it from other soft tissue neoplasms. So, accurate diagnosis requires consideration of clinical presentation, tumor location, and patient demographics for appropriate management. Thank you. Next, we'll show a video regarding the surgery of this case. Thank you.
First of all, I'd like to thank the organization of the Congress to invite me. My name is Jesmar Volga Haddad Hurdy. I'm full professor of pediatrics at School of Medicine in Universidade Federal Fluminense, Rio de Janeiro, Brazil. I'm going to talk about coarctation of aorta, its importance for pediatricians and cardiologists. Coarctation of aorta is a narrowing of the thoracic aorta at the insertion of ductus arteriosus just after the left subclavian artery. It's a relatively common congenital heart disease, around 5 to 10% of all congenital heart defects. The type A on the left side, the aorta narrowing of aorta is just in the ductus area. The type of B, the construction, the narrowing of aorta is before the ductus and displaying the cyanotic blood going to the aorta, and then there is cyanosis lower limbs. In type of C is the less common one. The morphology, there is one folding of ductal tissues posteriorly composed of an intimal and medial component that can extend around all the circumference of the aorta. The thick intimal and medial reeds protrude posteriorly and laterally in the aortic lumen. The microscopy of coarctation area. The intimal thickness at the constriction area consists of a fibroelastic component, which is congenital, and a fibrous component, which is acquired and progressive. This progressive element caused by deposition of fibrin and produces abnormal intimal surface and a turbulent blood flow because of the failure of removing of the abnormal area during the surgery, which explains the recurrence of coarctation in many cases of after surgery. The rupture of intima causes aneurysma, which is one of the complications. The clinical presentation, it depends on the severity of narrowing. It ranges from unnoticed disease to severe heart failure in newborn. Symptomatic disease usually follow one of the three patterns. You can find one infant with congestive heart failure, and which is a very catastrophic illness, or sometimes a baby, hydropic baby intrauterus because of severe heart failure. You can find one child with systolic heart murmur, or you can find one adolescent or adult with systemic arterial hypertension. This disease is very difficult to detect prenatally. The infants is necessary to keep prostaglandin infusion intraarterial continuously to keep this, in case of severe coarctation, to keep the ductus opened. Frequently is associated to other lesions as ventricular septal defect and aortic stenosis. Frequent symptoms are hypertension, severe headaches, and syncope. In physical examination, you always find diminishing of femoral pulse relatively to radial pulse, systolic hypertension in upper extremities, in systolic heart murmur, severe lesions you can find a cardiogenic shock, and cyanosis in lower limbs is observed in case of right to left shunt. In chest X-ray may be normal, or you can find cardiomegaly, or you can find dilated descending aorta, and rib notches in inferior edges of the ribs caused by tortuous collateral arteries. The electrocardiogram can be normal, or you can find signs of left ventricular hypertrophy or enlarged left cavities in case of severe hypertension. The echocardiography and Doppler, it's the first line modality to assess the diagnosis, PET diagnosis. It localizes the anatomy of the aorta, estimates the gradient, can assess systolic and diastolic function, the ventricular mass, and also the architecture of the valves. Cardiac computer angiotomography, it provides a superior space resolution, the vascular anatomy, morphology of coronary arteries. In CT angiography, this test provides a spatial resolution, evaluation of vascular anatomy, aortic dimensions, volume and morphology of coronary arteries. This figure is the posterior view of dimensional reconstruction of arterial phase of CT angiography in a baby 8 months old, showing focal reduction in the isthmus portion of the aorta. Cardiac magnetic resonance, or MRI. The radio waves create detailed images of the heart and blood vessels. It can show which part and how much the aorta is narrowed. The angiography is the gold standard test, used to evaluate severity of coarctation and aortic arch anatomy. The treatment of drugs. In newborn, you should keep prostaglandin in intra-arterial infusion continuously to make the dilatation of ductus and ductus-dependent defects. In heart failure, you should keep inotropic agents, as dobutamine, which also reproduces vasodilatation. Digoxin, which decreases the heart frequency, reduces the IV conduction. Diuretics as furosemide, and beta blockers, selective B1 adrenergic receptor blocker as metoprolol. In hypertension, you should keep antihypertensive drugs as angiotensin-converting enzyme inhibitors. The interventions, surgery or invasive heart procedure. The selection of technique, it depends of the age of patients, the anatomy of the aorta, the previous, if there is or previous repair. The interventions, either surgical or transcatheter therapy, balloon, angioplasty, and stenting, are indicated for significant hypertension in any age. Surgery is the gold standard in neonates because of recurrence. In case when it's done the balloon angioplasty, there is a many frequently recurrence. Surgical in infants from 3 months to 1 year are the best results. Interventions beyond more than 5 years can cause residual hypertension. Balloon angioplasty. This is the case when a patient with a very severe coarctation, and after the angioplasty, there is a release of the narrowing. Surgical repair techniques. You can do resection end-to-end anastomosis, or you can do a prosthetic patch aortography repair, or you can do a left subclavian flap aortoplasty repair. The outcomes, survival rates range from 93% in 10 years, 83% in 20 years, and 73% after 30 years. This is Mayo Clinic series. Surgery is better than stent balloon angioplasty in native lesions. Complications, aneurysma, pseudoaneurysma, recoartation, stent fracture, and narrowing. Other complications frequently are systemic hypertension, brain accident, heart failure, rupture of aneurysma. In conclusion, aortic coarctation is a narrowing of thoracic aorta. Clinical presentation can range from catastrophic heart failure in newborn babies, children with a systolic murmur, asymptomatic for many years. The thoracic echocardiogram is usually the first line modality for diagnosis. Treatment is surgery or balloon stent angioplasty. The survival rates are between 75 and 93% after 10 years, Mayo Clinic series. The complications are hypertension, recoartation, heart failure, and aneurysma. Thank you very much for the attention.
The topic of my presentation today is the role of atherosclerosis of coronary arteries in precipitating sudden death even in the young. Look at here, indeed, that is, this is all the causes of sudden death in the young. The first one, indeed, is coronary artery disease, atherosclerotic coronary artery disease, not a congenital, like in an adult. And this is 18% of all these cases. We collected 690 in this period, so it's a big number. This is the age interval in between 1 year and 40 years. So you see here the incidence among the age group. Of course, none under 10 years, but in between 12, 11 and 20 years, that is starting the cause of coronary atherosclerosis, and is increasing with time up to you see here is 70% of cases of atherosclerosis were within the age interval in between 31 and 40 years. Okay, so in other words, atherosclerosis is a cause of sudden death not only in the elderly, not only in the adults, but it may be a cause of death even in the young. Okay, so look at this is the classical atherosclerotic plaque of coronary artery, which is the cause of sudden death. This is not the classical plaque with atheroma and fibrous cap. No, it's a hard plaque in the absence of evidence of cholesterol there. So, and how this plaque may cause sudden death, we will see later. Okay, so what is the culprit plaque in the young that precipitates sudden death? That is usually is a single vessel disease located in the proximal left anterior descending coronary artery, and the morphology of a plaque is smooth muscle cell proliferation, like a tumor, with a small or even absent lipid core. And as far as what is the mechanism of occlusion of a coronary artery, no, it's not so frequent as in adult. It's less frequent than the adult thrombosis. We will see that there is a functional mechanism that is occluding the coronary artery plaque. Look at here. This is when I do an autopsy or sudden death, both in young or in the elderly, the first cut that I do is in the descending coronary artery, proximal one, and indeed you see here with your eyes that the coronary segment, the proximal of the descending, may be occluded like that. So it's a very simple diagnosis mechanism of investigation. Okay, so this is the phenomenon that is typical of the young. It is not lipid infiltration, is not atheroma, is proliferation. Look at here, this is a proliferation of smooth muscle cells. Where are they coming? From the tunica media or in the lumen? Most probably, this is a transformation of the endothelial cells in smooth muscle cells. This is a phenomenon. It's not occurring in the elderly. It's occurring very early when you are young because there are risk factors, and the most important risk factor, sure, is smoke. Okay. So, sudden death. I mentioned that we have 790 cases that we studied, and among these 155 were atherosclerosis coronary artery disease as a cause of sudden death. And as far as what is the mechanism? This is thrombosis. Okay, thrombosis is in 39%, whereas 61% do not show thrombosis. They are purely proliferation. And as we will see later, this is a proliferation of smooth muscle cells that are synthetic, but they are also contractile. So, as far as the plaque rupture instead, the thrombosis, the remaining 39%, this thrombosis may be due, as in the elderly, plaque rupture, but is much more important and frequent is plaque erosion, which means there is no rupture of fibrous cap, there is damage of endothelium, and there, and this inflammatory infiltration, that is an inflammation that may account for endothelial detachment. And this is called the thrombosis because of plaque erosion, because of detachment of the endothelium. Look at here, this is a classical one. It occurs also in the young, but this is very rare indeed. This is the classical plaque with atheroma here, with fibrous cap here, and we know that this combination of the two, large atheroma, thin fibrous cap, is at risk of what? Rupture. Rupture because there is a release from a macrophage of metalloproteinases with proteolytic activity accounting for the disruption of the cap fibrous cap. And look at here, when you have the rupture of the fibrous cap, this is a condition sine qua non for having the thrombosis then here. And this is a thrombosis complicating plaque rupture. And look at here, and this indeed, this is occurred in a male 35 years old only. And this is, you see that the fibrous cap ruptured, and there was, you see here, cholesterol cleft that are going outside and creating thrombosis and created lumen occlusion and sudden death. This may occur also in the young indeed, because this was a male of 35 years age, nothing else. Okay, and now the second mechanism of thrombosis is the endothelial erosion. This is, you know, the theory endothelial damage is the starting of atherosclerosis, but is the starting also of sudden death because of thrombus deposition there. Look at here, this is eccentric plaque. You see there is a thrombosis here, but the thrombosis was not created by rupture of the plaque, was created indeed by endothelial erosion. And if you look at here, the endothelial erosion is due to inflammation of the endothelium, and this is the basis of erosion. And look at here indeed. But what is impressive, look at here, it's very important. This is another case of sudden death in the young, 29, because of thrombosis. But strange enough is that the underlying plaque was not with critical stenosis. In other words, there was no possibility to prevent this thrombosis because the patient was not affected by pain because of stenotic plaque. This is a thrombosis because of erosion, and look at here, due to per se the presentation of the disease causing sudden death. And look at here, what do you compare? The part of the endothelium of the intima, which is intact, and this was CD31 immunohistochemical staining. But you will see on the other side, where the thrombosis started, you see that indeed, you see these are endothelium, but detached, and detached because of inflammation. So the basis of endothelial erosion mostly is an inflammation there. We don't know whether this is infected. Probably no. Probably is immunological, but there is inflammation. And how many times we observed acute myocardial infarction in these cases of sudden death in the young? None. We observe, of course, wavy fibers. That is a symbol, of course, of ischemia, but it's not an overt myocardial infarction. Rarely there was a previous myocardial infarction that accounted for scarring, and this is 1 in 4. 1%, and in all the cases of sudden death, you see here, okay, but not due to myocardial infarction acute. Okay, and look at here, this is a rare case indeed in the young. I don't know, it was a 39-year-old young, and you see here scarring. You see here the subendocardial scarring. This is a blue of Azammalori staining, and you see that this patient had so severe coronary atherosclerosis. But anyway, this is absolutely rare. Look at here now. The destiny of the plaque. You see here, this is a smooth muscle actin, you see here. So the majority of proliferation close to the lumen is they are smooth muscle cells. They are mesenchymal cells, but smooth muscle cells. And as mentioned before, I believe that this is a differentiation coming from the endothelium. And look at here. This is the proof that proliferation may the cause of a functional obstruction then of the coronary lumen and accounting of sudden death. Look at here the story of this patient. He had chest pain. Chest pain, they did, you see, the coronary angiography. Okay, we are in descending coronary artery. You remember the artery of sudden death, as German pathologists say in the past centuries. And you see here, there is a stenosis. What happened? It was during registration of the electrocardiogram, you see what happened. That is, there was recorded first the elevation of ST segment that is in keeping with acute ischemia, and then there was recorded the fibrillation, ventricular fibrillation. When we did the histology of this small segment, what we found? We found that the lumen was mostly occluded because of proliferation of smooth muscle cells, not a thrombosis or mural thrombosis. And don't forget that there are two types of smooth muscle cells. There is the synthetic type, the equivalent of blast fibrocyte, that is, of course, producing then the you see here that is proliferation of the cells, okay, but of synthesis, a synthesis of extracellular matrix. But among the smooth muscle cells in the intima, and not necessarily in the tunica media, there are the second one, the contractile type, with a very peculiar immunostaining, different from the synthetic type. This contractile means not morphological substrate of the occlusion. It is functional because there is a contraction there, and this account for transient the XT segment elevation, which is in keeping with coronary spasm. So look at here. When we did indeed in this case in which we recorded sudden death, look at here. You see ST segment elevation. Now transient. And then at the reperfusion of the blood, the was ventricular fibrillation and sudden death. This is the mechanism, functional mechanism, not thrombotic, of sudden death. And when we did the histology and immunohistochemistry in this case, we found just once subocclusion because plaque, subobstructive or obstructive class. And when we did a specific immunostaining, the contractile type of smooth muscle cells was found indeed in the intima. In other words, the intima and the lumen will undergo obstruction because of contractile activity of smooth muscle cells in the intima. Okay, so finally, conclusion. The plaque instability in the young may be either structural, with thrombosis, mostly due to erosion, or functional, due to superimposed vasospasm with vessel hyperactivity, because there are contractile smooth muscle cells in the intima as well. So this is the unstable coronary artery ischemia, and is structural because there is thrombosis. But this instead is functional, and both are instable. In other words, the coronary artery instability may be functional and may be morphological with substrate. So, the second conclusion, atherosclerotic plaque in the young sudden death victims shows abundant smooth muscle cells with a contractile phenotype. In the setting of critical stenosis, intimal smooth muscle cell contractility, together with a preserved tunica media, of course, might contribute to vasospasm and transient coronary artery occlusion, precipitating sudden death. This is a typical phenomenon that may occur in the young. Thank you very much.